একটা বাড়ি ছিলেন, তারপরে কি হয়েছে আমি জানি না।
সল্ট লেকে ছিলেন?
হ্যাঁ, এ জানে, রূপক রূপক সেই জমিতে গিয়েছিল। বোস যখন জমি দেখতে যান, রূপককে নিয়ে গিয়েছিলেন সঙ্গে করে।
আমি ভাবছি জন ক্রফটনের সাথে কাজ করেছেন, এরকম অভিজ্ঞতা ভারতীয় কজনের হয়েছে? স্যার জন ক্রফটন। এখন ওই বইটাকে সাহেবরা আর এডিট করছে না বলে, নালে ধীমানদা, ওটাই হচ্ছে চেস্টের বলতে পারেন প্রথম প্রামাণিক বই।
কার বই?
এই জন ক্রফটনের বই।
হ্যাঁ, জন ক্রফটনের রেজিস্টার ছিল। ক্রফটনের বইটাই প্রথম বই।
হ্যাঁ, ওইটাই ব্রিটিশদের উচিত ওগুলোকে আবার মানে রি এডিট করে করে ওটাকে আপডেট করে ফেলে,
এডিট করে পাবলিশ করা আবার। হ্যাঁ, জন ক্রফটন কলকাতায় 2-3 বার এসছেন।
আপনি শুনেছেন?
আর ক্রফটনকে আমি ইংল্যান্ডে দেখেছি, একটা লেকচার শুনতে গিয়েছিলাম।
ভদ্রলোকের কি বৈশিষ্ট্য ছিল ধীমানদা?
ও মেইনলি ওনার জীবন শুরু ছিলেন টিউবারকুলোসিসেই। হ্যাঁ, পরে এডিনবরাতে রেসপিরেটরি মেডিসিন প্রফেসর হয়েছিলেন।
অনেক ছাত্র তৈরি করেছেন সারা জীবন ধরে, দেশ বিদেশে সব।
ওর একটা আমার বক্তৃতা সৌভাগ্য হয়েছে, আর সেটা ব্রম্পটনে।
শুনেছিলেন ব্রম্পটনে?
হ্যাঁ, ব্রম্পটনে গিয়েছিলাম না 15 দিনের জন্য কোর্স করতে।
আচ্ছা আচ্ছা।
তাই ইনগুরেশন লেকচার দিয়েছিলেন।
মানে ওদের দেশে তখন উনি অলরেডি বিরাট সম্মানিত, অলরেডি স্যার হয়ে গেছেন হয়তো।
হ্যাঁ হ্যাঁ,
স্যার তো ওরা সবাইকে করে না, বিশেষ করে একাডেমিক ফিল্ড থেকে স্যার করেছে মানে সাংঘাতিক ব্যাপার।
হ্যাঁ,
মানে স্যারটা আমাদের পদ্মবিভূষণ থেকেও বোধহয় বড়, জানি না আমি ওটা কি লেভেলে পড়ে।
হ্যাঁ হ্যাঁ, পদ্মবিভূষণ তো আমাদের এখানে এসব সম্মান তো পলিটিশিয়ানদের হুইমসের ওপরে হয়, আর
যারা পায় তাদেরকে কেউ চেনে না। স্যারদের জন্য তো আলাদা করে হাউস অফ কমন্সে নাকি একটা করে সিট থাকে ধীমানদা।
ওদের সব অনেক শিলা শার্লককে ওই ডেম শিলা শার্লক করেছিল, কিন্তু শিলা শার্লক কখনো কলেজের প্রেসিডেন্ট হননি।
ক্রফটন হয়েছিলেন?
হ্যাঁ, উনি ওই লেডি নাইট হয়েছিলেন আর কি, ওরা ডেম বলতো।
ওরে বাবা,
ডিএমই।
কটা বাজলো? ঠিকঠাক কটা বাজলো রে?
7:28।
কজন লোক এসছে দেখতো? আজকে তো 28 জন ঢুকে গেছে।
28 জন
অলরেডি চলে এসছে, মানে গুড স্টার্ট। অন্যদিন এত লোক ঢোকে না,
গুড স্টার্ট।
শুরু হওয়ার পরে ঢুকতে শুরু করে। দেখা যাক আমাদের 2 চেয়ারটাকে যদি পপুলার করা যায়। আর সব
আমি তাহলে ওই মিনিট একটু ইন্ট্রোডাকশন বলে দিই, তারপর তুমি বলো।
একটু ইন্ট্রোডাকশন দিয়ে দেবেন। ওই আপনাকে মামার ইয়ে আছে, এই মেয়েটি শুধু শিক্ষা, ও আপনাকে ইন্ট্রোডিউস করে দেবে।
হ্যাঁ হ্যাঁ
স্যার, আপনি শুরু করার আগে একটু স্টার্টটা বলবেন, তাহলে আমি রেকর্ডিংটা শুরু করব ওখান থেকে।
তুমি যেই শিক্ষা বলতে শুরু করবে,
হ্যাঁ,
তখন থেকেই তুমি স্টার্ট করবে।
আচ্ছা আচ্ছা, ঠিক আছে ঠিক আছে ঠিক আছে।
শিক্ষা তুই 0 1 2 3 0 না 5 3 2 1 বলে শুরু করবি, তাহলে ও রেডি হয়ে যাবে। 5 থেকে যখন নামছি তুই বলে আমি স্টার্টিং কাউন্ট ডাউন।
ঠিক।
দেখ গলাটা আমাকে বিট্রে করছে আজকে, একটু চবনপ্রাশ খেয়ে নি। দাঁড়া, কি করবো, একটু একটু খাই। চবনপ্রাশের নাম করে দিই চবন প্রকাশ।
কাদেরটা কিছু চবনপ্রাশ?
ডাবর,
পতঞ্জলি,
তবে আমাদের বাড়িতে না ধীমান ছোটবেলা চবনপ্রাশ তৈরি হতো। বাবা এক গাদা আমলকি নিয়ে আসতেন, আর সেই আদা ফাদা এটা
ও চবনপ্রাশ আমিও খেয়েছি ছোটবেলায়।
এই দেখছি একটা আছে, গলাটা খুসখুস করছে, চবনপ্রাশ খাই।
Sir, it's already 7:30.
Fine.
So I think we need to start.
Okay.
So I'm beginning with the countdown. Okay, please get ready. 5, 4, 3, 2, 1. Good evening. I welcome you all to our Pulmocon session 2020. Today we are introducing you to a special session of our Pulmocon. And the topic for today is the two-chair test, a special talk in Pulmocon 2020, organized by Institute of Pulmocare and Research, Kolkata. To talk about 2CT or two-chair test, we have our eminent speaker, our organizing secretary and research founder, Dr. Parthasarathi Bhattacharya, who is the speaker for today. But before introducing him, I would like to take the opportunity to introduce our today's chairperson of today's session, Dr. Dhiman Ganguly. He is an MBBS and MD medicine from Calcutta University, MRCP, UK. He is a devoted academic activist, eminent orator across the country and abroad. Currently, he is associated with the Vivekananda Institute of Medical Sciences, Kolkata. He has also served as the Chairman of the Institute of Pulmonary Research and Medical Sciences,
কিরে ভয়েসটা চলে গেল
দিমান আপনি স্টার্ট করুন
also adored the chair of the
ওর শিকতার ভয়েসটা চলে গেল shall I begin?
Yes, sir, you can begin.
Okay. Good evening to all participants to an interesting evening session on a particular topic that is very close to my heart. Am I audible?
Yes. Yes, sir.
Close to my heart, it's exercise physiology. Exercise is a physiological stress on cardiovascular and respiratory system. Therefore, there are diseases where doing the test on at resting position usually may or may not give you the clues to the diagnosis. Therefore, you need to put cardiovascular and respiratory system to a little bit of stress to be able to manifest or find out the clues to the diagnosis of the disease. Now, this sort of oversimplification, people who complain of breathlessness on exertion may have diseases elsewhere, apart from the cardiovascular and respiratory system. For example, people with anxiety neurosis, people with anemia can complain of breathlessness on exertion. People with sedentary habits, people who are deconditioned for some reason or other, they can complain of breathlessness on exertion without any cardiorespiratory disease. Now, to differentiate all these, for a clinician who is seeing a patient who is complaining of breathlessness on exertion without any apparent evidence of either cardiovascular or respiratory disease is a clinical problem that we all face every day. So we need to have some test to put them on a little bit of stress and see the result. The exercise tests are popular for more than 30 years now. Initially, it was a 12-minute walk test. Then we reduced to a 6-minute walk test. But these tests are technically difficult and difficult to perform. For example, even for a 6-minute walk test, you need a 30-meter long hospital corridor, which is not easily available in many health establishments. You need a corridor with no interference for the patient to walk. When we advise a 6-minute walk test patients and people come back to you with a report, if you ask them, they will tell you that they could have walked faster. They couldn't do that because there were other people moving around in the corridor. That is why they didn't perform to the best of to the best of their ability. So to eliminate all the problems, we really need a test that can be done at a small space in every hospital and every private clinic, and they have a standardized response. This is necessary not only for diagnosis, but for follow-up of our diagnosed patients. If you have a patient with COPD who is complaining of breathlessness on exertion, you need some measurement of his effort tolerance as you follow him up with treatment. And the only way to do that is to perform some form of a exercise test. And today we are going to hear about the recent introduction and modification of exercise test in the form of two tests which have been published recently, and we have the author, Dr. P.S. Bhattacharjee, explain to us the relevance of this test, the technicalities, and the possible advantages. Over to Dr. Bhattacharjee.
Thank you, sir, for your tall introduction and making a wonderful platform ready for my talk. Cardiopulmonary exercise test is a big chapter. What I am going to talk today, let me focus my slides. Can you remove the slides and get my slides being focused? Please remove the introduction slide. Yeah. It's a pleasure and privilege for me today. This evening, I'm going to talk to you a new test called two-chair test. It's a simple exercise test in clinical medicine. Dr. Ganguly has already elaborated a little about 6 minutes walk test. It actually evolved from 12 minutes walk test in 60s. It's been very useful, but I will come to this. And today I can assure you that through my talk, which has got basically 2 parts, I will try to elaborate what is exercise test. I will talk a little about the 6 minutes walk test and its limitations. Then what is the requirement of a new test and how did I went to start this new test? You can say sort of mini innovations. And what was my task to see this test being validated and how did I do it? And finally, what is the use of this test in COVID time? So if you take the first part up to the validation of the test, this is the part 1. And the second part is the application of the test in COVID era. So let me start. Exercise test is important to understand the functional capacity, to quantitate disability of a person, to understand the competence of the cardiopulmonary system, what Dr. Ganguly has just elaborated, and to objectively record developments on or off and interventions. That's the follow-up. So in all these areas, exercise test forms a very important role. And there are many exercise tests. The 12 minutes exercise test initially started was soon replaced by 6 minutes walk test. This was being tested extensively across several cardiopulmonary disorders and been found very helpful. It's a validated and very well accepted test. Apart from that, there are other tests also, like shuttle walk test, seat and stand test. It is also validated test, which is meant for 1 minute or 30 seconds, 3-minute step test, and squat to stand test. This is 6 minutes walk test. Here, the gentleman walks on the corridor, which is 100 feet long, 100 feet plus because one has to turn. And he from one end he starts, goes to the other end, comes back, and ultimately at 6 minutes, we measure the distance he traversed. At the center, there is a chair so that he can take rest if he wishes. And the main issue is to measure the distance of walking for 6 minutes at his or her own pace. There are plenty of utilities of this 6 minutes walk test. It's a cheap, it's a very economic, easy test. The utilities are tremendous. The measurement of functional status is validated for COPD, cystic fibrosis, congestive cardiac failure, interstitial lung disease, peripheral vascular diseases. Apart from peripheral vascular disease, all the others are basically cardiopulmonary problems. It is also used for impact assessment of intervention, like in pulmonary hypertension, heart failure, COPD after lung surgery. And it is also helpful in prediction of mortality, like heart failure, COPD, and pulmonary hypertension. So you can see how useful is the test, but how frequently we do it,
Sir, please show your slides, sir.
Hello, sir. Sir, sorry to interrupt you. Your slide is not being projected.
But I can see my slides being projected. Okay, let me come back to the first and stop my slide and restart. Can you see my slide now? Please allow me a few minutes to come back. I'm closing it and I'll re-upload. Hello, I cannot see my photograph. I am disconnected.
I mean, we can see you, but your slides are visible.
I cannot see the panel anyway.
Slide ta asche na patto.
Well, let me rejoin. I think that's the best way.
Sir,
I'm sorry to the
connection
audience.
Sir, connection আছে আপনি খালি স্লাইডটা শেয়ার করুন হয়ে যাবে।
স্যার আপনি স্লাইডে স্যার শেয়ারে গিয়ে নতুন করে শোটা দিন স্যার, তাহলেই এসে যাবে।
I have
স্লাইড শেয়ার
to
করুন।
get to that level to upload the slides.
কানেকশন আছে আপনার?
I'm still connected.
হ্যাঁ, connection, you are still connected, you just project your slides.
In the bar, I can see only Shayoni Shengupta, nobody else. If had my name been there, I could have gone to my, I know I am visible, but
So you just share your screen.
so I have to get the place to share.
One more
that
time.
bar is not visible. Yeah, that's okay. I understand to share, but I cannot see that bar. You got my problem. I cannot close also. I'm trying to close and get from the very beginning. I'm still visible, I know, because the video camera is on.
We can hear, we can see you, but the slide not visible. একটু আগে তো হলো,
হ্যাঁ
একটু আগে তো তোমার লাইট গেলে শুরুতে, তখন তো দেখতে পেলাম।
হ্যাঁ তখন তো দেখতে পেলাম। আচ্ছা আমাকে একবার ডিসকানেক্ট করুন, আমি নতুন করে ঢুকি, তাহলে যদি করা যায়। Dimanda, ye panel
অপশনটা দেখতে পাচ্ছ না?
I cannot see myself. I can see only you in the panel. Whosoever I can see his face in a small black box. There is no bar above it. There's no bar anywhere where through I can manipulate.
স্যার তা একবার এক্সিট করে তাহলে ঢুকে যান।
দাঁড়াও, আমি ওপেন জুম মিটিং আবার মিটিং ওপেন করছি। আই এম সরি,
আমাদের
আই
এটা থেকে
অ্যাপোলোজাইজ।
এক্সিট করে নিন।
এটা থেকে এক্সিট করতে হলে বন্ধ করে দিতে হবে।
একবার স্যার স্ক্রিনের উপর একবার ডবল ক্লিক করে দেখুন একবার।
কিচ্ছু হচ্ছে না। এবার তোমার বক্সটা দেখতে পাচ্ছি।
হ্যাঁ, এটা আসবে স্যার, উপরে দেখুন, এখানে এবার স্ক্রিনের বাটনটাও পাবেন, নিচে আসুন মাউস পয়েন্টারটা নিয়ে।
না, আসেনি এখনো। বলছে এস্টাবলিশিং সিকিউর কানেকশন, আসেনি। এই জয়েন মিটিং এসছে, ইয়েস।
তাহলে স্যার ডিভাইসটা কিছু প্রবলেম করছে।
It's an earnest request to the attendees to please keep their patience. We're trying to fix the issue as soon as possible. Thank you.
হ্যালো
হ্যাঁ স্যার, হ্যালো,
হ্যালো
হ্যালো।
হ্যাঁ স্যার, হ্যালো।
হ্যালো হ্যালো am I audible?
Yes, sir, you are.
Acha. Okay, well, as long as the technical problem is not sorted out, uh, let me keep talking a little about exercise physiology. I hope Partho's technical problem will be sorted out very soon. The important point about exercise physiology is to keep the oxygen supply to the tissues intact uh, according to the demand. It's a very interesting thing that the originally exercise testing was introduced in training of athletes. The initial exercise testing machines were designed to train athletes to decide who will do better on a short distance running, who will do better on a middle distance running or a marathon running. It's interesting that Donald Lane, as far as I remember, an American athlete who was the first athlete probably who had his uh, exercise test done in sometime in early 1970s. Now, the measurement in those days that was given most importance was VO2 max. It was said that a VO2 max of less than 70 mil per kg per minute means the candidate has no chance in a world-class athletic competition. In our younger days, Roger Bannister, many of you will know his name as a neurologist, but Roger Bannister was a very good middle distance runner in 1950s. He was the first man to complete a mile distance. In those days, it was a mile. A mile distance is less than 4 minutes. His VO2 max, as measured in those days, was about 72 mil per kg per minute. As far as I know, uh, Dr. V.K. Vijayan in Chennai did some testing on our national level athletes with a cardiopulmonary stress testing machine. And he told me sometime in 1980s that none of our uh, national level athletes had a VO2 max of more than 55 to 60 mil per minute. That shows the kind of competition our boys and girls have to face when they compete in Europe or USA or at the Olympic level. So it's very interesting that the initial thing was done only for athletes. Then later on, people started doing a combined cardiopulmonary exercise testing uh, for patients. It was mainly used to differentiate heart disease, lung disease, and people who are deconditioned. The most important thing in this discussion was if somebody has both the diseases, if somebody has a mitral stenosis and the patient also has, say, COPD or asthma, then how much of his shortness of breath is due to mitral stenosis and what proportion is due to his COPD or asthma. That needs to be decided before one decides to operate on the heart. The same thing is true about people with ischemic heart disease and COPD. Now, people with ischemic heart disease, if they go to a cardiologist, they will invariably get a coronary angiogram done and some form of interventions done if the stenosis is found to be significant. But there are patients that come to us after having a coronary intervention done. They tell us that the breathlessness on exertion has remained just the same, even with the cardiac intervention. That means his breathlessness on exertion was probably more due to his obstructive airways disease rather than the incidental finding of coronary artery disease. Many of these patients with chronic ischemic heart disease with significant stenosis in their main arteries, either left, right, or left anterior descending, also have natural collaterals developed over the years. So, although the coronary angiogram is showing a stenosis, the man may not be suffering much from ischemic heart disease as the system has already developed uh, adequate collateral circulation. So these patients really, ideally, should have a combined computerized cardiopulmonary stress testing done. But unfortunately, the machine is very expensive. The technical training and expertise is not easy. You have to have very good. Partho, are you all right now?
Here I'm sharing just a slide.
Okay. Well, in that case, I hand over the proceedings to you then. You begin your talk.
Slide is, I can see the slide. Can you see my slide?
Now, I cannot see your slides. I can see you.
Okay. Can you see now? I can see the slides now. Now this has been projected at my computer.
শেয়ার হচ্ছে না তো স্লাইড আমরা দেখতে পাচ্ছি না
Oh, there is a great technical mistake. Anyway, Dhimanda,
আচ্ছা
let us share
you
between
can
me
carry on without slides.
Okay. Okay. I can just go on talking. People may be able to see me. I do not know what is the
Sir,
problem.
sir, in
Uh,
case you are not being able to project the slide, kindly send it to me. I'll try to project and you can speak then.
Take time. Let us play between Dr. Ganguly and myself. We'll try to make people understand as far as possible. Even closing eyes, we can see sometimes
Okay.
what is going on. So,
Uh,
Dhimanda, you continue on. Then I will
Okay,
interject.
well, if you are on, then
Yeah,
let me ask you a few questions as
yeah,
introduction to your talk. Then eventually, if the technicalities are sorted out, we will see the slides. Uh,
right.
Tell me briefly, this two-chair test. How far apart do you place these chairs?
Yeah, Dhimanda, let me please allow me to start the story a little
Okay,
from the little earlier stage. See, once
okay,
I was interested in treating pulmonary hypertension in COPD patients. As you all know, that
uh-huh.
COPD in advanced stage develops pulmonary hypertension, and that actually adds to the suffering of the patients. It reduces the functional capacity. It makes the quality of life worse, and it also compromises the survival. So I thought that why shouldn't we try treating COPD, PH in COPD? That was in roughly 10, 11 years ago. So I started looking at literature. There was not much. By 2009, one guideline was published by European Cardiology Society and European Respiratory Society. And that guideline said that you do not treat class 3 or group 3 COPH. So it was an inhibitory instruction. But simultaneously, there was an American guideline that said experts can treat it, provided certain clauses were there. So I thought there is some light, some hole, some light is coming. We can perhaps treat it. So I started slowly. Meanwhile, I got a patient in 2010 who had pulmonary hypertension. I looked at pH from echocardiography. My job was to diagnose pH because at that time, and even today, right heart catheterization is not a well practiced investigation, and we had a lot of problems in getting right heart catheterization done. The mindset is against right heart catheterization. Cardiologists are busy with left heart catheterization, coronary angiography, but hardly interested in right heart catheterization. Cost is involved, risk is involved. So we had to abandon that right heart catheterization. We tried to uh, make a feasible diagnosis of pulmonary hypertension without right heart catheterization. I went to radiology. I looked at chest X-ray features, HRCT features, echocardiographic features, and then I decided, well, we can have a clinical, echocardiographic, and radiologic criteria to diagnose PH. Of course, in that case, your diagnosis is not perfect. There is no hemodynamic data. You can say there is pulmonary hypertension with 100% specificity, but you cannot say what is the pulmonary artery pressure exactly, although your your echocardiography gives a value. So with that, I got a patient who had pulmonary hypertension. I tried my best in him for COPD. Everything being exhausted. He was given long-term oxygen therapy, and he was out to say, do anything, whatever you wish on me. I want to be a little better. Even if I'm not better, you can experiment on me. So I got a consent from him. I started him in low-dose sildenafil, and luckily he improved. And it actually opened my eyes. I thought, why not try? Then I was very skeptic to give treatment initially. I know that people don't accept it because there is no guideline. Still, I went on giving treatment to some patients, those who are really crippled with COPD and pulmonary hypertension, and those who are in functional state, WHO stage 3 or 4. So it went slowly, but I pulled it on. Meanwhile, in 2003, one article was published in the European Respiratory Journal by Anton von Nudegraaff. He is an international authority from Amsterdam on pulmonary hypertension. So he directly wrote, no, definitive no to sildenafil in COPD PH. So that was actually a more inhibitory influence on everyone. It was supported by lack of evidence. So I went to the evidence. I read those articles and I found that they are very disorganized kind of studies. The endpoint was different, the methodology was different, the number was small in most of the cases, and the hemodynamic data was also different because some people looked at pulmonary artery pressure, some looked at something else like that. And moreover, they started with a higher dose of sildenafil, 50 milligram TDS, 25 milligram TDS. I thought that if a patient has got COPD, he has got a distinct VQ mismatch, and if you give a vasodilator in the dose that you start for pulmonary artery hypertension or idiopathic pulmonary hypertension, then you are possibly going to precipitate some kind of VQ mismatch, and that might actually deteriorate the patient. So I stick to my idea of starting low dose and continue and giving slowly building up the dose. In 2013 itself, there was one more article in the same journal, European Respiratory Journal. It showed that as you see the COPD patients higher and higher in their in the spirometric severity, the chance of pulmonary hypertension is more. If you make a cutoff of say 20 millimeter of mercury, and on the left hand side you keep patients who are less than 20 millimeter of mercury pulmonary pressure with pulmonary hypertension, you'll find gold 2, gold 1, and maybe 1 or 2 gold 3, hardly any gold 4, very severe COPD. But if you come beyond 30, 35, you see all a gold 4. So if you have a sick patient who has got a very poor lung function, if you have got no other things to explain, and if your echocardiography shows pulmonary artery pressure high, if it is radiologically supported, clinically, if you see the patient is desaturating, then you are sure this patient has got pulmonary hypertension. And by then, some literature came out, a little later in fact, that COPD, the life expectancy of COPD PH is worse than idiopathic pulmonary hypertension. We have been carrying an idea that IPH is the worst of the whole lot. This survive only a few years. But these people have shown on hemodynamic parameter that lung disease associated pulmonary hypertension has even worse prognosis. So it actually strengthened my idea and emotion that we should try to treat PH and we should find out some way. So this Anton Von, he helped me a lot. I have kept his picture in my lecture today. So I saw another article in 2008 where he tested cardiopulmonary stress test in COPD patients and patients of COPD PH. And he commented that low saturation and a drop and decline in saturation in patients with COPD are maybe a diagnostic for COPD PH. So it gave me a lot of confidence. That was 2008, and this was around 2014-15. So I thought, why not try a desaturation test to see the patients of COPD PH. So my patients were evaluated on clinical radio echocardiography plus a desaturation test. Then I looked at 6 minutes walk test. I had no access to 6 minutes walk test. Before that, I had an access, but by then it was closed. It was a 70-meter corridor, 70-feet corridor I found, and I felt, no, I should not violate the protocol, I shouldn't do. Then I started making this patient walk in front of my office on footpath at Salt Lake. But the footpath is undulated. There are some driveway getting into the road, and this is not even. And I felt it is not wise. Otherwise, the people from the other side started peeping at us, wondering what these crazy people are doing. So we dropped it. Then I got the whole business into my office. I'm in office, and I made a 15-meter walk test. So 7.5 meters on and back 7.5 meters. But there was also problem, like people are coming in between, a lot of interventions, so interruptions. So I thought, no, this won't work. Then I came to 2-chair test. I felt it's okay. In front of me, the patient will make an exercise. From one chair, he will move to the other chair. Then a question of standardization came. What you have just asked me. Simple chair, I measured the height. It is some 48 centimeters from the ground. 2 chairs are kept front to front, and the distance between them from their front edge to front edge is just 5 feet. So 5 feet distance, 2 chairs kept. The patient is allowed to sit on a single chair, and pulse oximeter is placed on his finger. We observe the saturation and pulse rate, and once we found that it is stable for 30 seconds, then we ask the patient to stand up, walk to the other chair, sit there, then immediately stand up and come to the previous chair. That makes one movement. People say one round of movement. Whatever it is, it's one movement, and we ask the patients to do continuously 5 movements. So I made a format of keeping records, and I got it through my ethics committee, and I made it like the patient's pulse and saturation will be measured at the beginning, immediately after the exercise, and then at every 10 seconds for 2 minutes. So we find a trend of pulse rate change and trend of saturation change post exercise. What happens immediately after the exercise? We find the pulse rate is much higher than the baseline, and the saturation may be same, maybe a little higher, maybe a little lower, depending upon the underlying cardiopulmonary physiology. I used to do in all patients, maybe a normal person, anxiety neurosis, asthma, COPD, ILD. So it became a practice habit. And by now I have got some 10,000 patient records. Some of them are also repetitions on follow-up, but I have got a huge record with me. But my focus was towards COPD. And I found that those I diagnosed as PH, they have got a higher desaturation. So I measured the baseline saturation. I measured the bottom line of the saturation or the lowest saturation. And the gap I named a desaturation maximum. So that was named as desat max. So colloquially, in our chamber, we call it desat max. What is a desat max? Sir, it is 5. Sir, it is 4. Sir, it is 3. It is 2. If it is less than 3, there's nothing much to think. If it is more than 3, we found the patients are pretty sick. They are in the class 3 and class 4, be it NOIHA or be it WHO. So the sick patients, they show class 3 or class 4 WHO functional class, and they show more saturation. And then we decided that we'll give treatment to these patients. So we had a protocol, initial protocol for treating COPD PH. Now we started giving vasodilator to these patients. And then we looked at the result. So now I have got 2 jobs in my hand. Before you ask me the next question, my first job was to validate my approach of treating COPD PH, and the second job is to validate my test, that is 2-chair test. So this is how 2-chair test evolved in last 10 years with me. It was evolved to its final phase in 2016 or so, maybe late 2016 or early 2017. Devanda, what is your next question?
Okay. So in your publication, did you mention all the data of COPD ILD patients with 2-chair test, or was it just the technical part of the test?
No, Devanda, actually, I told you that I had 2 mandates with me. One is to establish treatment of COPD PH. The other is to validate this test. So let me come by one. The first job of establishing the mandate of treating COPD PH. Then we started giving patients treatment with the desat max more than 3. And of course, with consent, of course, with thorough evaluation and protocol, except right heart catheterizations. And it was also passed by my ethics committee. And we collected patients. We included roughly 170 patients. Ultimately, somewhat close to 100 patients, they agreed to the treatment. And of that, we had around 67 or 68 patients who were treated, and there were 27 patients who didn't qualify. That means they didn't have, although they had clinico-radiological evidence, clinico-radio-echocardiographic evidence of pulmonary hypertension, their desat max was less than 3%. That means they had less desaturation less than 3% on 2-chair test. So we didn't give them treatment, but we followed them. We give treatment only to those who had a desaturation of more than 3%. And that we followed after 3 months in terms of minimum saturation level and in terms of CAT score. CAT score is a health status measurement of COPD, which is very simple, which doesn't require any money. Basically, we are very constrained. So I had no other option. No repeat echocardiography, of course, no question of right heart catheterization, but on a simple test like CAT scoring and the saturation trend in saturation. What we found that the CAT score, it changed dramatically. From 15 point something, it dropped down to 12 point something. So that 3 plus or close to 4 unit difference in CAT score actually is actually translated in a very good response in our patients in functional terms, in their terms of satisfaction. We didn't at those time kept any other record like Borg scale or any other visual analog scale, but we are very happy these patients are doing well. And on that basis only, we found that those who had less than 3% desaturation, they were remained same. There was no statistical difference between the initial and after 3 months in their desaturation and in their minimum saturation level. So it was published in a this.
People who had more than 3 desaturation,
Yes.
did they improve and come back to less than 3 desaturation?
No, actually, yes, they improved. Their minimum saturation went up, and the desat max dropped significantly.
Right.
That's what I meant. That desat max was significantly reduced, and their CAT score was significantly improved, significantly reduced. So we are happy. The patients were also happy, and we published it. It was published in 2018, but the major flaw was that it was not hemodynamically supported. We didn't do right heart catheterization. So what we felt that we must have to do right heart catheterization, and somehow we could manage it. And by now I have done roughly right heart catheterization in roughly 55 COPD patients.
Right.
But my initial 17 or 18 patients data I tried to publish, and I'm very sorry I cannot project that all. That's a very interesting part, and it actually each step I move, it opens a horizon. The next step I go, it opens another horizon. Here, once I went for right heart catheterization, I hope Dr. Shubhanand Roy and Dr. Devanu Ghosh Roy are listening. I found that my patients with more than 3% desaturations, they have got a significantly higher pulmonary vascular resistance. That's highly significant. And their transpulmonary gradient was also significantly higher. But their pulmonary artery wedge pressure was almost similar. So may I take a little shift a little here to impress my audience? What are all these? So you have to imagine that as if our heart has been divided into two parts. There is a right heart and there is a left heart. As if these two hearts are brought together and being attached so that there is a right heart and left heart. There is a septa. Right heart ejects blood to the lung and left heart ejects blood to the system. Whatever amount the right heart ejects, the same amount is being ejected by the left heart. And the cardiac output is the same for the left heart and the right heart. So if you think of the cardiovascular reserve, the reserve of the right heart and reserve of the left heart are same. You can't make something like the left heart is good and right heart is poor. If the right heart is sick, the left heart has to be sick. There is an interventricular dependence. There is common muscular sharing. So they work in tandem. It's a wonderful system. Once you look at heart, I don't know how God makes such a wonderful plan and makes things like it. It cannot be, replicated. I'm very sure it's a wonderful thing. Anyway, what I found that if what I mean to say, the once blood is ejected from the right ventricle, it goes to the pulmonary system, and the pulmonary vessels are ramified into huge capillary base, 70 square meter of capillary, so that 5 liters or 4 liters of cardiac output a minute is distributed over a small ground, and then it goes to the venules and then goes to the left heart. What we do, we measure the pulmonary right atrial pressure, then go to the right ventricle, then go to the pulmonary artery, measure the pulmonary artery systolic pressure, pulmonary artery diastolic pressure, then we make a mean pulmonary artery pressure. We further progress and wedge the catheter into pulmonary arterioles, and we try to measure the pulmonary venous pressure or the left atrial pressure. So once we do a hemodynamic measurement, we are actually measuring the left atrial pressure, which is represented in pulmonary artery wedge pressure. We are measuring the pulmonary arterial pressure, and if we deduct the pulmonary artery wedge pressure from mean pulmonary artery pressure, the difference between the two pressure from the right end and left end, from the right heart to the left heart, from the ejection point of the right heart to the acceptance point of the left heart, this difference is transpulmonary gradient. And this transpulmonary gradient, if it is increased, then that means there is something problem in the pulmonary vasculature. And we have to remember that all these drugs, the sildenafil, ambrisentan, bosentan, whatever you say, they work on the pulmonary arteriolar system, the pre-capillary part of this whole circuit. This circuit has a pre-capillary part, a capillary, and a post-capillary. So actually, these drugs all work in the pre-capillary part. Just imagine a situation where the left heart pressure is raised. There is a mitral stenosis. The left atrium is huge. The left atrial pressure is, say, 25. And this back pressure has been transducted into the pulmonary system. And you measure a pulmonary artery pressure. But if the left heart pressure is high and the left heart pressure is 25 and the pulmonary artery pressure is, say, 35, mean pulmonary pressure, the difference is 10. Here, there is no indication of treatment. The pulmonary vascular resistance will be low because this resistance is calculated by dividing this pressure difference with the cardiac output. So we have to have a difference of more than 12 at least. In our all patients of COPD-PH, once I went for the hemodynamic study, what I find that the pulmonary artery mean pressure is raised. It is well around 30, 31, 32, some 29, maybe 1 or 2, 35 or more. They are all severe COPD patients, but their pulmonary vascular resistance is high, maybe close to 2.5, 3 times to those who have got low DSAT max. But the but is that both the group with DSAT max more than 3 and DSAT max less than 3 have got high pulmonary artery wedge pressure, means high left atrial pressure. Why the left atrial pressure is high? There is no shunt, there is no valvular problem. It's possibly, but all of these patients have got left ventricular dysfunction, diastolic dysfunction. There are no systolic dysfunction. So probably this diastolic dysfunction has a role to play for the raised pulmonary artery wedge pressure. I talked to many times to Dr. Roy and Dr. Ghosh Roy. We couldn't explain. I also raised a question because there may be, falsely raised pulmonary artery wedge pressure. They negated it. From the very beginning, we see consistently all the patients have got more than 15. The mean pressure is more than 15 in my series. So this has opened another horizon. But whatever it is, that's a different story. The fact remains that DSAT max can differentiate patients who are indicated for vasodilator treatment for pulmonary hypertension.
Are there questions from the audience, Partho?
Is there any question? I am ready to answer.
If there are, how would they put their questions? Would it be in a question and answer box or?
No, they can chat. They can put their question in the chat box, and you can ask me, and I can reply.
So
are they still hanging on after?
Let me invite anybody from the audience to put any question they would like to be answered by Dr. Bhattacharjee.
If can not, I can
go. Chat box?
I can go to the technicality of the 2-chair test a little more.
Acha, okay, go ahead.
Okay, now this my first mandate I have served, and I know it needs some far more refinement. I don't say it is a recommendations, but at least this I believe in a way to treat COPD-PH. But this is to be validated because in science every observation has to be repeated and has to be supported by far more evidence, bigger evidence, and then finally it is accepted. So I'm leaving this part. I'm going to the other issue, the technicality of the 2-chair test. There are a lot of things people should know. One is that in 2-chair test, why it is 5 movement. Initially, when I started 2-chair test, I made, and this is actually post-exercise recovery response measurement. Here, during exercise, we are not doing anything. In 6 minutes walk test, during exercise, you are not intervening, but you are measuring the walk distance. You are measuring the functional capacity. You are not measuring anything post-exercise. Here, you are measuring post-exercise recovery response. Why did I go for post-exercise recovery response? In fact, I had no other way to go this way. It came spontaneously, but when I looked back, I found it has been a boon to me. Because once we exercise, it's a global physiological response. It's not that our heart pumps extra. It's not that we breathe extra air in. It's not that our muscles become more toned up. It's the whole system that is changed. So while exercise is a global response of the body, and this response is submaximal. We don't exert to the maximum if we go for 6 minutes walk test or 2-chair test. Both the tests are similar in a large extent. Both the tests are submaximal, but both the tests are different. In 2-chair test, we see the functional capacity in terms of distance been walked, and in 2-chair test, we look at the recovery response in terms of pulse rate and saturation. This recovery response actually is more cardiopulmonary specific, because once you take rest after exercise, your muscle.
Partho, just a minute, but you are also measuring effort tolerance. You are counting the number of cycles that the patient is managing to perform. Isn't that right?
I'm counting the number of
cycles, number of changes of.
Yeah. I'll come to it, Manda. I'll come to it. So what happens once the patient takes rest, his muscles and other system, they become they take rest, and they are not that active. They maybe that they are not back to their pre-exercise status, but they are somewhat inactive. But now what is acting is the recovery part of the cardiopulmonary system. So if the patient has got any cardiopulmonary defect, the recovery will be defective. Simple logic. If you have a good pulmonary reserve or cardiac reserve, your recovery will be faster and better. Your recovery will be normal. There will be no aberration in the recovery measurements. But if you have got a disturbed, distorted, jeopardized cardiopulmonary system, your recovery will be defective. And this recovery I am measuring simply with the pulse rate and saturation. See, Dhimanda told deconditioning. If you see a patient of deconditioning, if you make him exercise in 2-chair test, we have seen in plenty of patients that the patient's saturation does not change much, but his pulse rate shoots up much. So there is a trend of recovery response in deconditioning. Now, coming to the question of 5 movements. So what I did initially, we chose 10 volunteers, 10 or 12 volunteers, and asked them to perform the test on 4 movements, then rest for an hour, 5 movements, then rest for an hour, then 6 movements, and then 7 movements. And we saw, and we also subjected the patients to 6 minutes walk test. And following 6 minutes walk test, we did the same post-exercise recovery response. These 2 tests are not similar, so I cannot measure the same thing as I do in 6 minutes walk test. So I measure the same thing in 6 minutes walk test vis-a-vis 2-chair test. The thing is the recovery response. So I made them to undergo 6 minutes walk test, and I measured the recovery response for 2 minutes, as I do for my 2-chair test. And I did 2-chair test with 5 rounds, 4 rounds, 6 rounds, and 7 rounds. See how people cooperate us. They cooperated me, and I found that it matches the best with the 5 movements. So I selected 5 movements.
Okay, but time is not important. You just make them 5 rounds.
5 rounds.
No timing is necessary.
Yeah, I measured the time also. One of my friend once raised the question of time. So after that, this is
somebody can do it slowly. Somebody can do it.
It is submaximal. It is at his or her own pace. You should not encourage the patient. You'll just, as you feel comfortable, move from one chair to another and come back and go again and come back. Do it as you do your best. Don't take any extra exertion for it. There is no target that you have to finish in 1 minute or so.
But in 6 minute walk test, you encourage the patient to walk as fast as you can, as fast as you can.
Himanda, there are different schools of thought in it. Some people, they encourage at every round, they encourage, okay, carry on, keep it up, very good, like that. And some people said, don't encourage. So it's not a similar, but if you encourage people, do encouragement at every level. Means whenever the patient comes back, at every time the patient is tested, do it in the same method.
That's right. Because unless he performs to his best, the result will vary from test to test.
Yes.
Depending on his mood.
Yeah. Suppose one is not given encouragement, and next time he is given encouragement, there may be a difference of 30 meters. Nobody knows more. Yes. Here there is no question of encouragement. It is his or her own pace. He can stop, stand in between. If he ultimately he has to finish 5 movements. If he cannot perform, he can discontinue. In that case, we write.
Do you record the time he
Yeah,
takes to finish 5 movements?
Yeah. We are now recording. We have seen that time has got nothing to do with the desaturation. The distance, the patients who have undergone both 6 minutes walk test and 2 chair test, the distance walked doesn't correlate with the desat max. What correlates, time also doesn't correlate that well. That has been available in the paper, all we have published, all these observations. And we have got certain indications, certain contraindications also. Like any patient with shortness of breath is indicated. But if the patient has got severe cardiopulmonary dysfunction, gross left ventricular failure, history of myocardial infarction within 4 weeks of the test, and got severe any other systemic disease, they are not included. If the patient has got dysrhythmia, if the patient is on, for the research sake, we discarded patients. We did not excluded patients on pacemaker, but I don't think pacemaker is a strong contraindication. It can be done on pacemaker also. So there are 7 or 10 contraindications also that we also elaborated. We also elaborated the method. We also elaborated the precautions. What should be ready and who should do, how to train. Basically, it's also important to train your technician, train your assistant, because if you do not train, they won't be able to understand the signals, the red signals. The patient might fall sick, or there may be, luckily with us, no untoward event has happened in last 3.5 years. All the patients could carry out. Whenever the patient stops, we let him stop, sit. We have got an oxygen cylinder ready, and that's not a big deal. Oxygen can be kept in a chamber as a precaution, but there is no question of giving a defibrillator. If the patient cannot, we just measure the pulse for 30 seconds. If the saturation is not improved, we give oxygen. I had to give oxygen in 2-3 occasions in last 2.5 years. But my people are pretty smart. They can understand if the patient is sick, they call me. I just examine the patient. I say, no, don't do it. If the patient is very sick, never. So these are the things we do in check before doing 2 chair test. So coming to validation, in my next mandate. So shall I go ahead, Devendra?
Yes, go ahead. And
my next mandate was validated.
Let us finish by, say, in another 10 minutes.
Oh, there is one more chapter, COVID. So that will take another 5 minutes. So give me another 15 minutes.
Okay.
So my next mandate was to validate the test. So in validity, there is 2 areas. One is the reproducibility of the test. That means if you do the test now, if you do the test after half an hour, if you do the test tomorrow, if the patient's cardiopulmonary physiology is not grossly altered, the test will remain similar. Suppose you have got a heart failure and you have given Lasix today, and tomorrow you are asking the patient to do the same test, I'm sure the patient will perform better. What we did, we took a group of volunteers whom we repeated the test after 1 hour in the same day. And we found that these 2 sets of tests on same patients, they are exactly similar. There was a fantastic overlapping. I could have shown you the picture, and the correlation is close to 97-98%. It's a wonderful correlations. And there is a statistically, I'm going into details, it is very similar. So it is highly reproducible. It is better reproducible than 6 minutes walk test. Now there is a question of comparison. Comparison with what? Comparison with the gold standard. That comparison we have done with 6 minutes walk test. In 60 patients, we have done 6 minutes walk test, and followed by that, we measured the pulse and saturation in the protocol for 2 minutes. And in the same patients, on the same day, after a substantial rest and stabilization, we did the 2 chair test. And we looked at the changes. There's also very good correlation. The changes in the 2 chair test and the same changes after 6 minutes walk test, they actually were overlapping each other with a correlation coefficient more than 93 or 94%. So it's you can say in this regard it is comparable to 6 minutes walk test.
Okay. Partha, if you can just finish up with little bit reference to COVID, post-COVID patients.
This is a very important issue in COVID. What we require, we want to diagnose the patients early. We want to assess the progress of the patients. Once the patient is admitted, we want to treat the patients. Once the patient is discharged, we have to look for the recovery, and we have to rehabilitate the patient. Happy hypoxemia, everyone knows. In COVID patients, we have got experience that patients say, I'm okay, but the saturation is 92%. In such patients, where the patients are saying, I'm okay, there is a pulse oximeter. It is showing 94%, 95%. I have got ample example, ample evidence that these people, once they walk, they desaturate. People say, do 6 minutes walk test. A lot of paper, a lot of social media posting has come to me. Do 6 minutes walk test and see desaturation. It's a horrible 6 minutes walk test. I couldn't do. How come everyone do? That is impossible. But 2-chair test, everyone can do. If you do a two-chair test and see the desaturation, desat max. I had 3 cases for you. I couldn't show. I'm very sorry. They are wonderful cases and each exemplifying a particular situation. One is the happy hypoxemia. The patient was admitted despite his resistance and my insistence that you must be admitted. He was about to be on ventilator, somehow escaped and stayed at the hospital for 14 days, recovered. Post-recovery, the scene is post-recovery. On day 7, he had again a desaturation. Now he was quite compliant. He was a good boy. He was listening to me. He was measuring his saturation. He had a desaturation. And desat max came down to 9 again. So I was in a fix. I was asking him to get admitted. He was reluctant. Then I thought what all could be possible anyway. So I gave antibiotic. I looked at his chest X-ray. I did a HRCT chest. And there was evidence of post-COVID fibrotic changes. And 4 weeks, I've got all records with me. And 4 weeks down the time on treatment, he has response. And the chart will show beautifully how the things are changing and how the desat max is gradually improving. That is one situation. That is happy hypoxemia. Second is the patient is admitted. We do not know how the patient is going. We are waiting for the patient to be severe. No, you do 6 minutes, do 2-chair test every morning, evening, and see the desat max. 2-3 days. Or do thrice a day. I had a patient whom I did 3 or 4 times a day. He was rapidly desaturating. You know, these are all on telemedicine. These are not on face-to-face. And as he told me that from morning I have desaturated this, he was sending me charts. I could have shown you the charts been sent by my patients. And I told him, get admitted. So he got admitted, became well. And the third situation is rehabilitations. It shows beautifully how the patient's capacity is increasing, how the desat max is reducing, and how the patient is getting better. So you can apply this 2-chair test for early diagnosis, for suspecting COVID, even in asymptomatic patients who have trivial symptoms, they ignore it. We do not know how many of them have got really small bit of changes in their lungs. That can be unmasked by 2-chair test. Early COVID, happy hypoxemic situations. Following early COVID, which way it traverses towards established disease or towards betterment. Everything you can monitor with 2-chair test. And post-discharge, I have no access to, right now I'm not going to any hospital, so I don't have any idea how these patients on hospital in 6 state 2, whether they can perform 2-chair test or not. But post-discharge, it has got a fantastic role. You can diagnose patients who are having post-COVID pulmonary complications, including pulmonary fibrosis, and how these patients are behaving on time. You need not go for X-ray or CT scan. Your 2-chair test report will tell you which way you are moving. So I think in COVID time, it is very important, very helpful.
Okay, Partho, I think I will have to leave now. We had a reasonable discussion. In some future time, show us your slides or if possible, put it up in your website or somewhere so that everybody can have a look at the slides.
Thank you, Dhimanda. I beg to apologize from everyone because of this technological flaw.
These things can happen any day.
I assure that I will make a talk available at my website. We'll have a website from our institute. I request all my
so that everyone can have a look
to register with us with their email address. Is very simple, and we'll post them our developments whenever there is any program. Like we have still 1.5 months left with Pulmocon. there may be many more wonderful discussions. So next week, next Sunday evening, we have got ILD session, and we have got 3 very erudite speakers in it. Good topics, not been discussed otherwise. Nowadays, in the time of plethora of webinars, we find the same thing being repeated, but it is not a repetition. It is not going to be a repetition.
Okay.
So with this, I
Yeah.
beg to leave. If there is any
But
question,
I offer
you can forward me.
great deal of thanks.
Our institute's website is www.pulmocareindia.org, and if anybody wants to contact me, IPCR, small letters, IPCR, Institute of Pulmocare and Research _India @yahoo.com. So they can contact me. And if anybody wants the proforma, I can send the format in which I keep. I wish people who are interested in a little bit of record keeping and research, they can keep the patient's record on it. And if they need any assistance from me, any suggestions, I can help them. I will try. So with this, I thank you all. Thank you very much.
Thank you. Thank you. I declare the session closed.
Thank you very much.
Thank you, Partho.
Thank you.
Okay.
স্যার আরেকটাবার একটু ট্রাই করে দেখুন স্যার যদি শেয়ার করা যাচ্ছে কিনা, কেন অসুবিধে কোথায় হলো?
কি হলো ভগবান জানে রে ভাই, আমার আছে।
শুরুতে তো দেখলেন সুন্দর আসছিল, হঠাৎ করে কি হলো?
দাঁড়াও, আমি এটা সব বন্ধ করছি, তুমি থেকো। আচ্ছা, এটা কতজন এসেছিল গো আমাদের অডিয়েন্স?
স্যার 53 জন।
53 মানে এসে চলে গেছে কেউ না সব ছিল?
স্যার অনেকেই চলে গেছে, এখন 32 আছে।
আচ্ছা আচ্ছা, ঠিক আছে। কারো কোনো প্রশ্ন থাকলে তুমি জিজ্ঞেস করতে পারো, বলতে পারো। বিমানটা চলে গেছেন, কেউ যদি কোনো প্রশ্ন থাকে আমার শিক্তা জিজ্ঞেস করে আমাকে বলতে পারে। So if there is any question, people can ask me. Shikta will be my research fellow, can help you to get the answers from me.
স্যার এর মধ্যে আরেকবার তবু আপনি একটু শেয়ার স্ক্রিনটা চেষ্টা করুন।
তোমাকে একটা কথা জিজ্ঞেস করি, এই যে আমরা মিটিং গুলো করছি, এটাকে মানে লোকে কিভাবে স্কোর করছে, এটা কি করে কিছু পাওয়া যায়? সাইমালটেনিয়াসলি বোঝা যেতে পারে যে লোকে কিরকম লাইক করছে, লাইক করছে না?
স্যার সেরকম তো কিছু চেকিং আপ তো রাখা নেই তো স্যার।
রাখা নেই না, ঠিক আছে। আমি এটা বন্ধ করে দিই, করে আবার
হ্যাঁ একবার ট্রাই করে দেখুন তো স্যার, আরেকবার শেয়ার স্ক্রিনটা।
এইখানে বলছে জুম 50।
কোনো মেসেজ শো করছে স্যার?
একটা বলছে জুমের ইয়ে ডাউনলোড করতে, জুম 5 ডাউনলোড করতে,
জুমটা আপডেট করতে বলছে।
ওইটার জন্য হতে পারে?
হ্যাঁ স্যার।
তো মোক্ষম সময় আপডেট করতে পারে কেন?
আর স্যার এগুলো তো কিছু করার নেই। আগের বারের প্রোগ্রামের সময় আমারও ল্যাপটপে ওরকম হয়েছে, আপডেট করতে বলেছে, প্রায় 1 ঘন্টা নিয়েছে আপডেট করতে। এই তো সুন্দর আসছে,
এখন আসছে। তো আপডেট ছাড়াই আসছে, তখন আসছিল না কেন? তুমি একটু তোমার সিস্টেম দেখো, আমার তো ঠিক কম্পিউটার ঠিকই আছে।
স্যার আমার সমস্ত ওকে দেখাচ্ছে, আপনার পার্টে সমস্ত পুরো গ্রিন আসছে।
তুমি আমার স্লাইড দেখতে পাচ্ছ
না? আপনার তো পিডিএফ ফাইল দেখতে পাচ্ছি, 2CT Pulmocon 20 লেখা আছে দেখতে পাচ্ছি।
দেখো এখন স্লাইডটা আমি তুললাম, জাস্ট আপডেট ইয়ে করলাম, আপলোড করলাম।
আপনি কোন একটা স্লাইড চালান দেখি।
এই তো স্লাইড তুলেছি, তুমি কি দেখতে
না
পাচ্ছ?
একটা স্ক্রিনে আটকে আছে।
আচ্ছা, স্লাইড চালাবো?
হ্যাঁ কোন একটা স্লাইড প্লে করুন।
এবার চলছে
না, আগের স্ক্রিনে আটকে গেছে।
তুমি স্ক্রিনটাতে কি লেখা আছে?
স্ক্রিনটায় স্যার অনেকগুলো আইকন দেখাচ্ছে, একটা ফোল্ডার ওপেন হয়েছে যেখানে 2 চেয়ার টেস্ট 2020 আছে, আর অনেকগুলো আইকন দেখাচ্ছে, পিডিএফ ফাইল আছে,
ওখান থেকে আর খুলছে না, আমি কিন্তু খুলে ফেলেছি এখানে। ওখান থেকে
এইটা স্যার শেয়ারিংটা আটকে যাচ্ছে, আপনি এটা জুমটা আপডেট করুন।
হ্যাঁ শিক্ষা, কিছু বলছিস? ঠিক আছে, সবাইকে ধন্যবাদ। আমাদের কি করে কি করতে হয় সেটা দেখতে হবে এরপরে। এটা খুব বাজে হলো আজকে।
শুরুটাতে এত সুন্দর স্লাইড দেখা যাচ্ছিল, ঠিক টাইমেই আপডেশনটা নিয়ে নিল।
আপডেটের জন্য হয়েছে কি অন্য কোনো কারণে হয়েছে কি জানি
না? না একদম একদম আপডেটের জন্য হচ্ছে, ওই জন্য স্ক্রিন এসে আটকে যাচ্ছে। আপনার স্যার জুমটা একটু আপডেট করে নিন।
উফ,
আপডেটটা যখন দেবেন স্যার হাতে একটু সময় রাখবেন, কেন 0.5 ঘন্টা 35 মিনিট মতো নেবে।
ও, ঠিক আছে, এটাকে বন্ধ করি, করে আবার জুমে ফিরি।